discuss about the INI-CET dermatology, especially the high yield point discussion. In INI-CET, it consists of AIMS, DIPPER, and PJ. We know they will mainly ask the previously asked questions in a bulk. Almost 30 to 40% questions will be previously asked. At least the topics would have been previously asked. So today we are going to focus on the previous 5 question papers of INI-CET, and we will see how to solve those questions and some important points. First, we will start from the previous INI-CET November 2022. The first question: Chromoblastomycosis is characterized by option A, sclerotic body engulfed by macrophages, option B, angioinvasion, option C, asteroid bodies, option D, grain with fungal elements. They have given the image also. First, with the question itself, it's a chromoblastomycosis. We know chromoblastomycosis is a deep fungal infection characterized by a body known as chromo, means copper, you have to remember. Color, so copper penny bodies. But if you see the options, the copper penny body is not there, so you should not get confused. The other name for copper penny bodies are sclerotic bodies or medullary bodies. The image itself, you can make out there are multiple brown colored round structures. Here it is engulfed in a macrophage. So the answer here is sclerotic body engulfed by macrophages. This is the correct answer. We will see other options in which conditions they will come. This is the chromoblastomycosis. It is caused by Cladophilofora. Carioni and Fonseca bedrosi. The clinical feature is warty lesions, warty or verrucous lesions along the warty lesions in the exposed areas like legs. This is clinical. In histopathology, we have discussed it is copper penny bodies or medullary bodies or sclerotic bodies. Then another option given us angioinvasion. Angioinvasion is characteristically seen in mucormycosis. That's why mucormycosis lesions have that eschar. Because of angioinvasion, there is thrombosis, so there is an eschar. Then another option was asteroid bodies. Asteroid bodies are seen in a fungal infection known as sporotrichosis. Other than that, asteroid bodies are seen in a condition known as sarcoidosis. The fourth option was grain with fungal elements, which is a characteristic of mycetoma. Mycetoma is characterized by 3 things. Clinically, there will be a swelling or nodule, and there will be discharging sinuses. And third one will be grain discharge. Yes. Is there any doubt you can put in the chat box? The next question is, a patient presented with papular lesions. What is the histopathological finding in this case? The image was given like this. In this The options given are Anderson-Peterson bodies, collocytes, Zang cells. If you see the image, this is the epidermis and this part is the dermis. There is an epidermal invagination. Almost it is mimicking tomato. If you cut the tomato, it will be look like this. There will be multiple septa with multiple seeds in this. This cut tomato appearance is characteristic of molluscum contagiosum. Now you guys can tell what will be the finding in molluscum contagiosum. Which bodies will be there? In molluscum contagiosum, the bodies present is, yes, correct, Anderson-Peterson bodies, or otherwise known as molluscum bodies. The image you can make out, these are molluscum bodies. These round purplish structures. Yes, this is the clinical image. In molluscum contagiosum is caused by pox virus, characterized by umbilicated papules, with molluscum bodies. And tell me, where will be collocytes? Okay. Chat disabled. Can host people enable the chat section here? So collocytes are seen in warts. Collocytes are nothing but normally keratinocytes will be like this, hexagonal with central nuclei. If there is a HPV infection, the cells will become rounded and the nucleus will push to periphery. Something like this. This is the collocyte, which is characteristic of HPV infection. Wart. Then Jank cells are basically acantholytic cells. Acantholytic cells seen in pemphigus group of disorders. Yeah, 1 minute. If you have any doubt, you can ask in the question answer section. I will answer in that. So Jank cells are acantholytic cells. We know acantholytic cells are seen in pemphigus group of disorders, right? Next question asked was Fite faraco stain is used for A. Mycobacterium leprae, B. Mycobacterium tuberculosis, C. Amyloidosis. For this question, we should know the common stains used for each condition. For Mycobacterium tuberculosis, we know it is Zn stain with 20% H2SO4 as a decolorizer. For amyloidosis, we know it is Congo red, thioflavin T and all. In Mycobacterium leprae also, it is Zn stain with 5% H2SO4. as a decolorizer. Na? You can remember in this way, Fite. Leprosy is the chronic disease. It is there in world for a long time. So you have to fight against leprosy, which is very important. Fight against leprosy is very important. So you can remember fight and fight. This way you can remember. Other than that, 5 fights. 5% you are using now, so you can remember in this way also. These are this. So the answer here is Mycobacterium leprae. This modified Zealandson strain is also known as the Fite strain. You can remember like this, fight against leprosy is important at the present scenario. And 5% you are using, so it is Fite strain. This is the Fite faraco strain showing M. leprae, which is a pink rods. For TB and leprosy, the differentiating feature is TB bacilli are long, these are short. TB bacilli lie singly, and leprosy bacilli will be in clumps, known as globi. These are some differentiating feature in ZN strain. 20% H2SO4, 5% H2SO4. That is very important. Right? Next question is, which one of the following disease has vesicular lesions? The options given are hand, foot, mouth disease, option B roseola, option C dengue. This we know hand, foot disease has a vesicular lesions. The lesions will be in the around and inside the oral cavity and the palms and soles. So the answer here is hand, foot, mouth disease. Roseola is caused by HHV and it is characterized by erythematous papules. Matters maculopapular rash. Dengue, we know it is characterized by Peteschia and purpura. When there is thrombocytopenia, in other important dermatological finding is there will be rashes which have islands of sparring, otherwise known as islands of white in the sea of red. This is the case of HFMD, hand, foot, mouth disease caused by Coxsackie virus. Vesicles in the oral cavity, palms and soles. For this kind of questions, we should know what are the possible vesicular lesions in infectious causes. For example, if we see bacterial, we know the impetigo, bullous impetigo is the important infection with vesiculobullous lesions. The name itself implies. In viral, herpes labialis and genitalis are common. These are caused by HSV 1 and 2. Another important thing is chickenpox and herpes zoster. That is hand, foot, mouth disease. Now we have seen in the question. Next, in the fungal causes, the important thing you have to remember is bullous tinea pedis. Although dermatopedic infections are annular in configurations, the tinea pedis, the tinea involving the soles and palms, can be bullous. So, bullous tinea pedis. Another is mycoplasma infection can lead to a condition known as erythema multiforme. In this, there will be a targetoid lesion or target lesion with a central vesicle. These are the common infections with vesiculoplus lesions. If you remember this, if similar question asked, you can answer this. Next question. A diabetic patient presented with asymptomatic lesions over the axilla which showed coral red fluorescence on wood slump examination. What is the causative organism? Option A, Corynebacterium minimalissimum. Option B, Candida albicans. Option C, Trichophyton rubrum. Option D, Trichophyton schonlenae. Here the image is also given, which showing the coral red fluorescence. If you see wood slump examination, which shows coral red fluorescence, you have to think about the condition known as erythrasma. Red means erythema, so erythrasma. This way you can remember. Coral red means erythema, so erythrasma. Erythrasma is caused by a condition, infectious agent known as Corynebacterium minimalissimum. So coral red, you can remember corny. So coral red fluorescence is seen in erythrasma, which is caused by Corynebacterium minimalissimum. If we see the other options, Candida albicans and Trichophyton rubrum doesn't cause fluorescence. So these options are out already. Trichophyton schonlenae can lead to fluorescence, but that will be blue-green. And Trichophyton schonlenae will lead to a condition known as favus, which is involving the scalp tinea or tinea capitis. So that is also not the answer. In this question, it is a straightforward coral red, Corynebacterium minimalissimum, erythrasma. These are the linking points you have to remember for this question. Now we will see some wood slump finding out some common infectious agents, so it will be helpful for you. Pseudomonas aeruginosa, we know whenever Pseudomonas is there, the color will be green. In Cutibacterium acne, it will be orange. Cutibacterium acne, if you want to know, it is the organism related to acne vulgaris. Initially, it was known as Propionibacterium acne. Now the name has changed. It is Cutibacterium acne. Next, in fungus, Malassezia furber, which is leading to P. versicolor, Pityriasis versicolor, which causes orange yellow or golden yellow color fluorescence. Trichophyton schonlenae we have discussed, which is causing favus, blue-green fluorescence. Microsporum also causing tinea capitis. This is also leading to blue-green fluorescence. Apart from infections, one of the conditions which is inherited is porphyria, which is related to heme synthesis defects like porphyria cutaneous tarda, congenital erythropoietic porphyrias. Those are characterized by red fluorescence, especially of, if you take urine sample, it will be red, and teeth, that is known as erythrodontia. Right? Don't worry that the written copy will be given to you. So just listen whatever I am teaching. Okay. Sixth question is porotrichoid pattern or nodular lymphangitis is seen in all infections except. Here in the image, in the leg it is beautifully given. There are multiple papules with crusting in a linear pattern. This is lymphatic spread or sporotrichoid spread. The options given are Staphylococcus aureus, Mycobacterium marinum, option C, Nocardia brasiliensis, and Sporotrichosis schenki. The name itself, we can rule it out. Sporotrichosis schenki won't be the answer because that will have obviously a sporotrichoid pattern. The other causes of sporotrichoid spread is nocardiosis, which is caused by Nocardia brasiliensis. So that option is also out. Then swimming pool granuloma. which is caused by Mycobacterium marinum. In aquarium workers or water related work, they will get that. So this option is also out. So after ruling these three options, obviously the answer will be Staph aureus. Some questions, if we don't know the answer directly, we have to rule out the unrelated option. So it will be easy for us to conclude. So for this question, the answer is Staph aureus. The points you should remember is the conditions is sporotrichoid spread are sporotrix Schenke, Nocardium residens causing nocardiosis, Mycobacterium marinum causing swimming pool granuloma, right? The next question. Black eschar over the back is due to which of the following? The image is given. There is a central black eschar with the peripheral erythema. In the image it is given. The options given are Rocky Mountain spotted fever, option B scrub typhus, option C COVID-19, option D malaria. If we see in the options, we have read malaria multiple times, so malaria is not the answer. We know that we can rule it out easily. Even COVID-19, you can rule it out easily. COVID-19 will lead to chilblain and pernio, not eschar. Eschar is obviously related to some infection or some insect bite which lead to that. So the most of you might have stuck with two options, which is Rocky Mountain spotted fever, another is a scrub typhus. Both are the tick and mite-borne disorders. So if you want to remember, in the rickettsial infections, only two infections will lead to black eschar. One is scrub typhus, another is rickettsial pox. These two infections only will lead to this. So obviously the answer here is scrub typhus. In dermatology, not only rickettsial infections lead to eschar, there are various infectious and non-infectious conditions can lead to eschar. Eschar is basically whenever there is a blood vessel occlusion, it will lead to necrosis and there will be dead of tissues which is adherent to base, very adherent to base, which is known as eschar. Vessel thrombosis or occlusion. If you see the infectious causes in bacterial, we know cutaneous anthrax will lead to eschar. Another is ecthyma gangrenosum, which is very important. It is caused by Pseudomonas, especially when the patient is having sepsis. Pseudomonas sepsis will lead to ecthyma gangrenosum. Another is a typhus, one is scrub typhus, another is a rickettsial pox. In fungus, in the previous slides we have discussed mucormycosis, which is having that angioinvasion property. So it will lead to eschar. And some spider and tick bites, without causing any infections, they can lead to eschars. In non-infectious, yes. Yes, I will finish this and I will answer your questions. Like in non-infectious, purpura fulminans, which is a cutaneous manifestation of DIC, disseminated intravascular coagulation. Second is a calciphylaxis, which is common in end-stage renal disease. These also can lead to eschar. Now I will answer your questions one by one. First one is a lymphangitis is caused by staph. Okay. Actually, in the image, if you see, the lymphangitis is nodular lymphangitis in a sporotrichoid pattern. Staph aureus can lead to lymphatic infection, which is lymphangitis, but this nodular lymphangitis is not seen in staph aureus. Okay, that is the point they have asked. One option was Corynebacterium immune and sporotrichoid spread. Corynebacterium immune will cause erythrasma. Erythematous hyperpigmented patch. It doesn't cause any nodules or papules. The morphology is mainly patch with coral red fluorescence. Okay, I hope you would have understand your queries. Now we'll move on to the next question. The following finding is seen in option A, systemic sclerosis, option B, SLE, option C, dermatomyositis, option D, rheumatoid arthritis. You see the image, there are multiple erythematous papules and flocks over the knuckles mainly. The image you can make out, right? These are known as Gottran's papules. Gottran's papules are characteristic of a condition known as dermatomyositis. Okay. Gottran's papules are seen in dermatomyositis. If you have the lesions over the knuckles, it is Gottran's papules seen in dermatomyositis. In systemic sclerosis, only hand feeding the patient may have is the tightening of skin over that area, which is known as sclerodactyly. Entire finger will become thinned, and there will be Raynaud's. Raynaud's, you know, I hope. There will be discoloration of the fingers, white, red, blue, whenever they are exposed to cold. In SLE also, the main finding is Raynaud's phenomena. In rheumatoid arthritis, they may have nodules, but they also have deformity because of joint involvement. So in the image, there is only flocks. So you have to think more of dermatomyositis, Gottran's papules. This is a case of dermatomyositis. Other cutaneous manifestations are also very important. If you see in the face, there is a rash over the eyelids, which is known as heliotrope rash. Purple rash, okay. In the neck, it is known as V sign. In the back, it is known as shawl sign. The thighs also, the patient may have these purpuric lesions, which is known as Holster sign. Right? If you seen SLE, we know malar rash, maculopapular rash can be there. This is the Raynaud's we have discussed just before. And here you can make out that paronychia and Raynaud's. In systemic sclerosis, we have discussed that sclerodactyly, tightening of fingers, and Raynaud's. The face, there will be telangiectasias, and nail pole capillary, there will be changes. The next question is, which of the following is not a non-scarring alopecia? The option A is alopecia areata, option B telogen effluvium, option C androgenetic alopecia, option D frontal fibrosing alopecia. This question, first you read the question properly, which is not a non-scarring alopecia. So they are indirectly asking which is a scarring alopecia out of this, right? This is the direct way. If you see in the options, you don't know which one is scarring, which one is non-scarring and all. In this option, you can make out easily. There is a condition given as fibrosing. Whenever there is a fibrosis, there will be hair growth. Na? So frontal fibrosing alopecia will be the correct answer in this question, right? If you want to remember properly what are the scarring and non-scarring alopecia, I will tell some easy way. First, we will start with non-scarring alopecias. Non-scarring alopecias, first, both effluvium are non-scarring. What are the effluvium? We know anagen, telogen, right? Both patterned hair loss are non-scarring. What are the pattern hair losses? Male pattern hair loss, which is known as AGA, androgenetic alopecia, and female pattern hair loss is non-scarring, FPHL. Then in tinea capitis, colorful tinea I have mentioned. You can remember there are four tinea capitis. There are gray patch, black dot, pavus, Kirian. You see colorful tinea means gray patch, which have a color in the name. Another is a black dot, which also having the color. Gray patch and black dot are non-scarring. And you know, mania is a condition, there will be intermittent periods of normality. Na? So you can remember in that way, trichotillomania is one of the non-scarring alopecia. Then alopecia areata is one of the non-scarring alopecia. And 2S. One is secondary syphilis, which is causing the moth-eaten alopecia. Alopecia. Another S is SLE. In SLE per se will lead to non-scarring alopecia. Among SLE, discoid lupus will lead to scarring. That we will see later. So in non-scarring, you can remember all effluvium are non-scarring, both pattern hair loss are non-scarring, colorful tinea, mania, area. So both finishes here. Mania, area, and 2S. These are non-scarring alopecia. In scarring alopecia, in papilloscomas disorder, you can remember lichen planopilaris, which is a scarring alopecia. In infections, we have discussed in tinea capitis, Kirion and Favus. The other two are scarring. And carbuncle can lead to scarring alopecia. In inflammatory conditions, there are conditions which have some clues in the name itself. For example, dissecting cellulitis of scalp. So there is a dissecting cellulitis. So there won't be any growth. Entire hair follicles are dissected. Another one, folliculitis decalvans. The name itself shows. Decalvans means it is entirely scooped off or something like that. Folliculitis decalvans. In connective tissue disorder, we have discussed now. SL is a non-scarring alopecia. In the opposite, the discoid lupus erythematosus is a scarring alopecia. In idiopathic, there is a condition known as pseudopellet of Brock. And we have discussed another thing. There is a name fibrosis. So frontal fibrosing alopecia is a scarring. Apart from that, trauma, burns can lead to scarring alopecia, right? You can remember easily. Especially if you remember non-scarring, you can answer this question also. So you can rule it out. So in the options, we know area is a non-scarring, so it is out. All effluvium are non-scarring, which is out. All pattern hair loss are non-scarring, which is out. So the answer here is frontal fibrosing alopecia. Next, finasteride mechanism of action. Option A, aromatase inhibitor. Option B, 5-alpha reductase inhibitor. Finasteride is a drug used in two conditions. In urology, benign prostatic hyperplasia. In dermatology, it is used in androgenetic alopecia. Because in androgenetic alopecia, there is a testosterone in males, which will convert it into dihydrotestosterone by an enzyme known as 5-alpha reductase, which leads to miniaturization of hairs. And there will be hair fall. Finasteride mainly acts by the mechanism which inhibits the 5-alpha reductase. So that is the answer. Aromatase inhibitor is different. Letrozole, anastrozole, those are aromatase. If you see, otherwise easily you can remember is like 5-5. So 5-5 you can remember. 5-5. Same way like Fite faraco is 5% H2SO4 for leprosy. Okay. Right, these are the questions asked in last exam. Next we will go to NEET May 2022. First question, a patient with satellite skin lesions presented to you. He also have one hypopigmented lesion and one thickened feeder now. The treatment best suited would be. They didn't give the options directly. They gave two images. One, you can see there is a green pack Another is a red pack. Packet A, packet B, they have mentioned. First, you will see what are there in green pack. Here itself it is mentioned. 2 rifampicin and 1 dapsone. So 2 drug regimen, which is a paucibacillary. In the image itself is given. This is a paucibacillary regimen. Here, if you see, there are R, rifampicin, dapsone, and clofazimine, and the pack itself is mentioned. It is a multi-drug regimen, multi-bacillary regimen. The options given are packet A for 12 months, packet B for 12 months, packet A for 6 months, packet B for 6 months. For answering this question, we should know when will you give paucibacillary and when will you give multibacillary drugs. So, according to WHO and NLEP, the leprosy is divided into paucibacillary and multibacillary based on 3 things. Skin nerve slip. If there is a 1 to 5 lesions, which is paucibacillary, if it is 6 or more, which is multibacillary. Whenever there is a 1 nerve, it is paucibacillary. 2 or more nerve thickened, it is a multibacillary. Slit skin smear will be negative here. Here it is positive for AFB. Now you can make out in this question. In the clues, they mentioned 1 hypopigmented lesion. So skin lesion is just 1. And the only 1 thickened feeder nerve. So the patient is paucibacillary case, right? What we will think in paucibacillary case, we will give multi-drug therapy, paucibacillary, 2 drug regimen. That was the previous treatment. That is the thing we have to remember now. If you see the present recommendations after 2017, this regimen is not in use, right? Only this regimen is used. Only multi-drug therapy, multibacillary regimen is used. That red kit. Only difference is in paucibacillary we will treat for 6 months. In multibacillary we will treat for 12 months. So from this question, what we will understand? We have to know some recent things also. So if we see the answer, it is a multi-drug therapy, multibacillary for 6 months. You will see it is packet B. So packet B for 6 months. So option D is the correct answer. Right? So in this question, the take-home point is that green kit is not used now. Paucibacillary kit is not used. Only multi-drug, multibacillary kit is used. 6 months for paucibacillary cases, 12 months for multibacillary cases. The next question they have asked like match the following. Like match the options in the column A with the correct options in the column B. The first is silvery, brany, mica, collarette. The disease site, pityriasis osseosa, psoriasis, pityriasis versicolor, pityriasis lichenitis chronica. Sometimes in these kind of questions, you have to at least try to solve 1 or 2 options, so it will be easy for you to find out others. For example, we know silvery scales are seen in psoriasis, which is a direct thing. So for option A, it is 2, psoriasis. That is that. Then if you see collarette of scales, we have discussed in previous classes also the collarette of scales, Christmas tree pattern, those are seen in P. rosea. So for D, which is option 1, P. rosea. Now we are left with 2 things, brany and mica scales. Brany means very fine powdery scales. The powdery scales are seen in a condition known as pityriasis versicolor. Even the word pityriasis means also it is powdery scales. So the brany scales are seen in P. versicolor. Okay. So we are left with mica. The only option left is micaceous scales are seen in pityriasis lichenoides chronica. So in this, the easiest options are option A, like silvery scales are seen in psoriasis and collarette scales is seen in P. rosea. We just think brany means powdery. If you see in P. versicolor, if you scratch the lesions, there will be powder-like scales from the back. So brany scales are seen in P. versicolor. So the only option left is mica. Micaceous scales are seen in pityriasis lichenoides chronica. So you have to know the nature of the scales and the conditions associated with it. The next question, for starting chemoprophylaxis in leprosy, which requirements and conditions should be met? they have given like multiple choice. This is almost like a PGI pattern where they will have multiple options correct. Like the options given are age should be more than 2 years, living with patient for more than 6 months, close contact for more than 20 hours per week, sharing same clothes and towels. In this, we have to know one thing. There is an NLEP criteria for chemoprophylaxis. National Leprosy Eradication Program given some inclusion criteria for chemoprophylaxis. First one is age more than 2 years. That is the important thing. Age more than 2 years. So that option will be obviously correct here. The second thing they have given, the contact is living with patient. For if it is more than 3 months, it is fine. With more than 20 hours per week exposure. They can live with the patient, they can treat the patient, or they can socially related to the patient. Live, treat, or socially related. So if you see the options, the first one is correct. Age should be more than 2 years. Close contact for 20 hours per week is also correct. They have given in the option it is more than 6 months. So it means less than 6 months they won't treat. But it is not like that. Na? If it is more than 3 months itself, we have to treat as per NLEP chemoprophylaxis criteria 2019. So this is somewhat a suspicious answer. Then fourth one is sharing same cloths and towels. So it is not directly given in the criteria, but they have mentioned if they live with the patient or treating the patient or socially